Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, you ready to talk about endometriosis?
I am excited to do so.
We had two expert guests, Doctors Isabel Green and Adela Cope. And of course, our co host, Dr. Carolyn Chan, was there helping us out too. And Paul, endometriosis, remind the audience, what is it?
It is the presence of, I want to make sure I have this right, endometrial-like tissue, not just endometrium, in places where it doesn't belong. It is actually causing symptoms of pathology, though not necessarily. You can actually have endometriosis, and one of the presentations can be being asymptomatic. It's common in that it happens in 1 in 10 reproductive age individuals who are born with a uterus or with ovaries, which is as much as like type 2 diabetes. That's as prevalent as another chronic disease that we deal with all the time. And yet I feel much less equipped.
Diabetes is easy to diagnose, Paul. This one is not.
Just exactly right. And as such, the diagnosis can be delayed for 7 years, up to 12 years in some studies due to variable presentations and lack of provider, or I should say clinician, comfort with the diagnosis or even thinking about it, and just lack of awareness because the tests that we have for it are imperfect and oftentimes are more used to rule out other stuff than they are to make the diagnosis.
But Paul, they only have pain during their periods, right?
I love that we're still doing this. Yeah, that's the other thing that it was an education for me during this episode is no, not necessarily. So pain can certainly occur outside of menses as well. So if you try to start treatment and then the pain is still occurring outside of menses, that does not mean that it's something else entirely. You still need to think of it because it's just so common and can present in so many different ways.
Yeah, and the symptoms, I mean, Dr. Cope mentioned that the symptoms, like, she thinks of if a patient comes with dysmenorrhea, pain with bowel movements, pain with urination, that trio of symptoms can make you think of it. If people are having pain with intercourse, that can be another one. There's a lot of the vague symptoms, fatigue and things like that. And then the patients, especially if it's gone undiagnosed for years, they may start to have other overlapping pain conditions like IBS, painful bladder syndrome. So, think of it in these patients that are having pelvic pain and maybe other pain conditions. It's something that you can think of. And Paul, tell me about the imaging.
If we're thinking about it, we would probably think to start with a pelvic ultrasound, and they've made the point it doesn't necessarily have to be transvaginal, though oftentimes that it will be. It depends on sort of patient's comfort with the examination itself. So you'd start with that, but you can't rule things out. And in fact, it may even take a little bit of additional training to recognize some of the more subtle findings that can actually be seen with endometriosis. And you may not have that at all imaging centers, but still, that's probably where you'd start. And if you're still very suspicious for it, the next step in workup would probably be a pelvic MRI because that's going to have better sensitivity for it than a CT scan would. And I think a lot of folks would probably reach for the CT scan because that's the imaging modality they have the most comfort with. But it turns out that the pelvic MRI is probably also a little bit more sensitive for it too. And that might kind of give your colleagues in gynecology a little bit of a head start in making the diagnosis or working the patient up.
Yeah, and part of the reason the diagnosis is tricky is not just the vague symptoms, not just the fact that the imaging can be negative. I mean, even on laparoscopy, our both of our guests were surgeons, and they were saying it can be hard to spot the implants because they can be superficial. They can also have these larger endometriomas, which are almost like these, almost look like tumor-like masses that they can get. But it can be hard to diagnose. Paul, you can start treatment even if you don't see endometriosis, but you suspect it because it is the surgery. Not everyone's going to go for surgery for a laparoscopy to look for it. So if your imaging is negative, but you suspect endometriosis, that's okay. You can still start treatment. And the treatment for it is really oral contraceptive pills. They can either be estrogen and progesterone containing, or that you can just use a progesterone only pill. And the guests were just saying a lot of patients may want to still have their periods. Some may not. So if they want to have their periods, they can go on cyclical contraception, or they can go on continuous ones if they don't want to. Or if someone's on cyclical and it doesn't work, you can try them on continuous. And if patients aren't responding and you've kind of reached your comfort with what you're doing medication wise, that's a good time to refer. I think for me, most times that I suspect this, I would probably be referring at this point because it does seem like most patients could benefit if you have an expert available to see an expert in this.
Yeah, our guests were talking fairly high level stuff to me, a simple country doctor, in terms of things like oral contraceptive plus IUD and sort of mixing and matching the various ratios of hormones. And So I may need to tag in
Yeah,
one of my colleagues to help once
it
we get to
going
that point.
yeah, going on like super high doses of progesterone,
Yeah,
which would not something that I'm familiar with either. But this, I mean, this episode I think is an essential one for most primary care doctors to listen to because it just has so many pearls. It's going to help you recognize what is a common condition and definitely help your patients and know what to do. So, if you want to hear more about this episode, because there was so much packed into it, then please click on the link in the transcript below to hear the full thing. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
sure enough, Matt. And I remain Dr. Paul Nelson Williams. Thank you and goodbye.